I think the issues that Sir Michael is going to bring to our attention will make you want to see things change in our country. Sir Michael is the most famous person in the world for looking at the social determinants of health and ill health. And as Arabella has said, he has written a number of great books, but he's also written a number of reports that have affected government policy in Britain and in many other countries around the world. And there are, what we'll talk about in a minute, Marmot cities that are springing up around the world that are following his ideas about how to create a more healthy population and a happier population as a result. So it's a real pleasure for me to bring Sir Michael Marmot to Kirkcaldy tonight and to say that I worked with him when he did the Marmot report more than 10 years ago, and he did an updated report on the United Kingdom showing that a lot needs to be done over the next few years. Now, I'm going to start by asking him a few questions, and then we're going to allow the audience, and I hope all of you will have questions that you want answered, and you'll feel able to put them through Arabella to Sir Michael in a few minutes. But thank you all for coming. Now, I suppose everybody is worried about the state of the NHS, and everybody has their own experience of the NHS. I just tell you one of my experiences. I was 16 and I ended up in Edinburgh Royal Infirmary because I got a rugby accident when I was playing for my school team, Kirkcaldy High School. And I ended up in hospital for weeks and then months because I had 4 operations. But the funny thing that I remember about my experience was every night at 8 o'clock in the ward that I was in, which was an ophthalmic ward, a trolley came round at 8 o'clock. I was 16 at the time, by the way. A trolley came round and asked, did you want wine, beer, Guinness, stout, lager? And this was the result of a bequest to the health services. I'm sad to say that we don't have free beer in the National Health Service at the moment. But everybody, of course, is now worried about the state of the NHS. Everybody knows that waiting lists are far higher. Everybody knows that the staff are under great pressure, and we'll have Wilma Brown speaking later about the pressures that the staff in the National Health Service are really under, both in terms of their remuneration, which is too low, but also in terms of the pressures that they're facing because of COVID and now through a series of other things. So the first point I want to raise with Sir Michael, and he'll direct the discussion in the way that he wants to, is what he thinks about the state of the NHS in relation to his work, obviously about health inequalities in our country. So, Sir Michael, welcome to Kirkcaldy. We are delighted to have you here. We know you could be in any other part of the world and have audiences listening to what you have to say, so we're very delighted and privileged you've come to Kirkcaldy. The first question everybody's asking, state of the NHS and what needs to be done. Sir Michael.
Well, it's an absolute pleasure to be here, and to be here with Gordon Brown, who, as he said, commissioned me. And I'm going to answer Gordon's question. I'm not a politician, so I will answer his question. But just to put it in context, I chaired the World Health Organization Commission on Social Determinants of Health. Alan Johnson was then the Health Secretary. And the question that Alan and Gordon put to me was, how could we translate the findings and recommendations of your global commission for one country, England? And they commissioned me to do... Gordon came to the launch of our WHO Commission report, which we had in London, and people said to me afterwards, the Prime Minister told a joke. They didn't say whether it was a good or bad joke.
That was before Boris Johnson.
The facts, people coming from all around the world, they couldn't quite credit the fact. So we produced that report, Fair Society, Healthy Lives, the Marmot Review. A few months after we produced it, the government changed. Predictably at the time, we produced it in February 2010. So the report that we did in February 2020 was looking back on those 10 years. We weren't primarily focused on the NHS. We were focused on the social determinants of health. But the NHS is the endpoint because we all need it. We're all going to get sick. I had one European health minister, when I was doing my European review, say, "You'll put me out of business. If you make everybody healthy, then, you know, my job's managing the healthcare system. You'll put me out." I said, "Don't worry. We're all going to get sick. We're all going to need it in the end. Hopefully a bit later in the piece than before, but don't worry, you'll have lots of people filling your hospital beds." And that means that the healthcare system is absolutely vital. The Commonwealth Fund, based in New York, despite its name, does regular surveys of healthcare systems in 11 advanced countries, and the NHS always came top. And in particular, in equity of access, we had the greatest equity of access of any healthcare system in the world. I haven't seen a recent report from the Commonwealth Fund, but you know what it would look like. We've slipped, and you can see it. Money isn't everything, people say. You can't solve everything from throwing money at it, they say. Well, during the period, I try not to be party political, but during the period that Tony Blair and Gordon Brown were Prime Minister, healthcare funding went per annum increase. It went up about 3.8% per year in real terms. Conventional wisdom says that healthcare funding has to increase by at least 2% a year above inflation, because growing population, aging population, and new priorities. So to keep steady, it has to be 2% above inflation, at least. And in the period from 2010 on, it was 1% above inflation, if that. I wrote a rant. It was called an essay, but it was really a rant in The Lancet about post-truth and politics. And forgive me, this is a technical term I'm going to use now. I distinguish between lies and bullshit. That's a technical term. The difference between lying and the other one, lying is you know what the truth is, and you're trying to distract people from the truth. So an example of a lie is £350 million a week on the side of the railways. That's a lie. You know what the truth is, and you're distracting people from the truth. Bullshit is an altogether more expansive occupation. It's trying to distract people from the truth. It's not obviously telling a lie. So, for example, when the Health Secretary, who's now the Chancellor of the Exchequer, said we're spending more on our healthcare service than we've ever spent before in our history, I don't know what you call that, but it was certainly misleading. Of course we're spending more, because we've got more people. The spending per person was actually going down. So although over the Parliament from 2010 on it went up at about 1% a year in real terms, which, as I've said, is below NHS inflation, it's not keeping steady, it then actually went down. And the effect of that, we can see 133,000 vacancies in the health service, doctors and nurses. Now, if there are more patients coming in and you've got all those vacancies, you either have to employ agency staff, which is ridiculous, or the existing staff have to work even harder. And the fury, the absolute fury of the union, boss, I think was Unison, when they actually sat down with their health secretary and he said, well, we might give you more money provided there's efficiency savings. What? If you've actually been in a hospital, seen what's going on in a hospital, working every minute of every hour, overtime, And the gall of talking about efficiency savings, and the reason I'm talking about this, no, it's not just money. It's conditions of work. It's belief in what people are doing. If you look at the number of people waiting for treatment, and I said the NHS is not my special domain, this is not what I do, but it's a statement of where we are as a country. The number of people waiting for treatment, there was a graph, that well-known left-wing journal, the Financial Times. It is pink, by the way, it is pink colour. But the FT, there's a brilliant data journalist, Bern Murdoch, he does brilliant things. And he looked at the number of people waiting for treatment. In the Thatcher Major government, went up. Labour government went down. Since 2010, it's gone up. This has got nothing to do with Vladimir Putin. This is what's been going on for the last 12 years. Yes, it's not helped by the war in Ukraine, but to say, oh, everyone, all countries are suffering, this was a conscious. I actually said on the Andrew Marr LBC interview the other night, last night, I said, I don't think it's just callous disregard, as if that weren't bad enough. I think it's active undermining. And the combination of callous disregard and active undermining, and it's not just because the NHS is our religion and all that garbage, it's because it's something very important. We all get sick and we all need health care. But it also says something important about the kind of country we live in. That we value a service free at the point of use that's available to everybody. WHO's big mission is universal health coverage, and we have it. I have a friend of mine who's a former city lawyer, a lovely man, and he said, look, I'm rich, why shouldn't I pay for my own care? And I said, because we end up with a two-tier healthcare system. Because if you pay for your care and other people, rich people, pay for their care, we end up with a two-tier system. The people who can't pay then get what's left over. And it's a basic principle that this is something for all of us. The thrust of my report in 2020 is that, and which I'll talk about in a moment, but the thrust of it was that the key drivers of our worsening health situation were not the healthcare system, but wider issues that I do want to discuss. More recently, what's happened over the last year or so is its lack of access to healthcare that's actually leading to excess deaths. It's people dying waiting for the ambulance, people dying in the accident emergencies. It is lack of access. And again, Bern Murdoch, I was talking to people at The Economist, I'm talking to people in these very mainstream, publications, and they're all concerned about what's happening with the healthcare system and that it's actually killing people. We are in a perfectly dreadful state, and the state of the NHS is symptomatic of it.
So Michael's work is about the social determinants of health and ill health. And I want to start with one of these statistics that you have been quoting from some of the newspapers. Two reports have come out this week on health inequalities in Scotland. One from our Scottish Future, and I think the author's here, you may want to ask a question, and one from the Health Foundation. And they've both been pointing to inequalities in healthcare, which means that the demands on the health service are that much greater, inequalities in health. But one statistic stood out. 10 years ago, people expected that someone born then would live to the average age of 90. But now they're saying now in 2022 that they will only live to the average age of 86. What has gone wrong? Is it all to do with COVID, or is it to do with health inequalities that have become more ingrained? How do you attribute the reasons for that figure, that life expectancy on average for people being born now has gone down 4 years and 4 months over 10 years? It's an astonishing statistic, isn't it?
So let me talk for a moment about my English report, and then I'll come to the two Scottish reports, because they're like the English report that I did, only more so. So the 2020 report, just before the pandemic, crashed upon us. It was looking back to the report that Gordon commissioned me to do, that we published in 2010. And what we showed, if you look at the improvement in life expectancy, so it relates to your question, if you look at the improvement in life expectancy over 100 years, for the whole of the 20th century, pretty much, life expectancy improved about 1 year every 4 years. Wow. 6 hours every 24 hours. Don't know what you did today, but at the end of the first 6 hours, you could live as long as you did before those 6 hours. That's pretty remarkable. Well, that's what it was like, and you think about it, in 10 years, life expectancy expanded 2.5 years. Wow. That's what it was like all through the century. I mean, some fluctuations with 2 great wars, but pretty much like that. 2010-11, that trend, there was a break in the curve. And the rate of improvement slowed dramatically and just about ground to a halt. What happened in 2010? Gordon will remember. We had a change of government, the Conservative-led coalition government. They said, when I produced some interim figures before the 2020 report, well, maybe we've just reached peak life expectancy. It's got to slow down sometime. So we looked at other countries, at the improvement. Every European country, Japan, Australia, all the rich countries, all had more rapid improvement than we did. We had the slowest improvement in life expectancy of any rich country except Iceland and the United States. We had not reached peak life expectancy. Something had gone on in the UK and the United States that was different to other countries. Second, we see a social gradient in life expectancy. Classify people by where they live, classify where they live by the level of deprivation, and you see a gradient. The greater the deprivation, the shorter the life expectancy. That gradient got steeper, but it got steeper in a very challenging way. Within England, and when I say Scotland, is even more so, within England, if you compare, let's say, the northeast region with London, there's a gradient in both regions. In London, life expectancy went up at every point along the gradient. The gradient got steeper, but in the northeast, life expectancy fell in the poorest 10%. It didn't go up in the next 10%. It didn't go up, didn't go up, didn't go up until you got to about the middle. And what you see is the gradient is steeper in the northeast than it is in London. If you're rich, it doesn't much matter where you live. The poorer you are, the bigger the disadvantage of being in the northeast or the northwest, or Scotland. And that's why I say the Scotland is like the English one, only more so. Now that's really challenging. We can all think why that might be the case. If you take a national index of deprivation, why its consequence for your health is bigger in the north of the country than it is in London and the southeast. It's not just north-south. In Italy, it's the opposite. It's bigger consequences in the south of Italy than it is in the north. So pre-COVID, three crucial statistics that lead me to say that our health was not good. The rate of life expectancy improvement had slowed dramatically. Inequalities were increasing, and life expectancy in the poorest area was going down. And then we turn to these two Scottish reports, and it's very clear in the Health Foundation report particularly, they've got very clear data. Dramatic difference in life expectancy between the least deprived decile and the most deprived decile. And life expectancy was going down pre-COVID in the most deprived decile. And so the gap was increasing. Just think what this means. You, I, all of us expect health to improve all the time. That's what's supposed to happen. Advances in medical science, improvement in standard of living. We expect health to get better all the time. And that's what's been happening. And now for the poorest people, it's not happening anymore. It's going down. And then came COVID. And we said at the beginning of the pandemic that the pandemic would expose the inequalities in society and amplify them. And if you look at England, and if you look at Scotland, the rate of decline in life expectancy got faster in the most deprived. It actually even went down in the least deprived. In England, it went down for the bottom 40%. I don't know what the exact metric is in Scotland, but it was really challenging for everybody. So the figure that Gordon cited, the overall expectation of life. Now, this is not a prediction, it's a statistical artifact, but the overall expectation for life went down, and the inequalities increased. And then, so that's two challenges, a decade of austerity, the pandemic, and then the third challenge is the cost of living crisis. It's too early to say what effect that will have on health inequalities, and scientists like me are not very good at explaining the past, let alone predicting the future. So we're cautious about predictions. But all the signs are that it will have a very damaging effect on physical health and mental health, the cost of living crisis. I mean, the reason I'm so excited by what happened over the road just now in what you're trying to do, we'll come back to it, is deal with a very real problem. I mean, what do we want a country to do to make sure that everybody can feed themselves, has shelter, that's adequately heated? They're pretty basic minimum. I've been talking about leading a life of dignity. I don't take Maslow's hierarchy of needs. I'm not for hierarchies. I think you need to have dignity at whatever level you are on the gradient of basic needs. And actually, not being able to feed your children, having to wear 2 overcoats indoors to stay warm, means you can't have a life of dignity. You can't have self-actualization because you can't get through the day. And that's where we are now for the poorest in our society. And in trying to explain what's going on, I was talking to a leading economist in Barcelona, and he said, "You don't know anything. You really don't know anything. We economists know everything. And what we know is that you don't know anything because you haven't got a big econometric model where you can put all the numbers in. And all right, we don't know anything. What we know is that over the decade, in England, child poverty went up. There have been some mitigating factors in Scotland that means the rise in child poverty wasn't as bad as it was in England. But child poverty went up. The spending on education over the decade from 2010 went down by 8% per pupil. We talk, the third of my domains was employment and working conditions. Let's just look at working conditions in the public sector. A war on the public sector. If you're, for whatever reason, motivated to work in the public sector, you've got to be shamed for doing it. We don't value you. We're not going to pay you. We're going to have terrible conditions of work. Number 4 is having enough money to live on, to have a healthy life. That's the 4th of my recommendations. Well, that's under severe threat at the moment. Number 5 is healthy and sustainable places in which to live and work. Just look at the housing crisis. And I think of housing in 3 ways. Affordability, that has a big impact on health potentially, because if you can't afford to have a decent place, then you either pay too much and don't eat, or it's very difficult. Affordability. The second is the housing quality, and I'm happy to talk about it in a moment. We produced a report on the 1st of September, Cold Homes, Fuel Poverty and Health Inequalities. And the third is a bit more nebulous, but maybe it's the most crucial. Security. Home as security. The respite, the refuge, the place where you can feel I'm at home, comfortable, that's me. Ontological security, as it's been called, but security. And all 3 of those are crucial. They're linked. So housing, transport, etc. And the 6th one is what I call taking a social determinants approach to prevention. And they've all been under threat. So we have ample potential explanation for this worsening health picture in England and in Scotland.
So Michael, this week in the Scottish report, the figures were very stark. Someone who is a man living in one of the deprived areas will live 14 years less than someone in an area that is not deprived. And 33% of their life will be spent in ill health. And a woman will live 11 years less if she's in a deprived area than a non-deprived area, and will have 35% of her life where she is unhealthy one way or another, whereas in the richer area it will be only about 10 to 15%. So you've listed a number of things that you are concerned should happen. Where would your priorities be to deal with that level of inequality that exists?
The first thing to say, what you've just described, is what I mean when I say Scotland's like England, only more so in the health picture. Because that 14 years in England is less between the bottom and top decile. We can get bigger differences, like in the London Borough, the Royal London Borough of Kensington and Chelsea, the area around Grenfell, where the Grenfell Tower, the hulk of the Grenfell Tower sits. The life expectancy for men there was about 16 years shorter than in the rich part of the borough, where the embassies are and so on. So we can get, but in general, what you're describing is bigger inequality in Scotland than in England. And that's why I say it's like the north of England, only more. Where would my priority be? My number 1 is to say, put equity of health and well-being at the heart of all government policy, whether it's central government, national government, regional government, city, local government. I have these 6 domains of recommendations that I just went through: early childhood, education, employment and working conditions, having enough money to live on, healthy, sustainable environments and lifestyle. And I certainly want to do that. But I want to put equity of health and well-being at the heart of all government policy. So that if you're the Scottish Government, if you're the Education Minister, you're not thinking about health in the sense of, we'll make sure kids can run around the park once a week. I mean, that's important, but that's not what I mean. I mean, we want to level up when it comes to the outcome of education. We want the kids in the most deprived areas, for their scores on national exams to approach those of the kids in the less deprived areas. At the very least, bring them up to the median of what's possible. If you're responsible for business, we did a report last year. I was saying to somebody earlier this evening, you know, the old adage, if you sup with the devil, use a long spoon. In public health, we've always seen industry as the enemy, for good reasons. Employment practices, smoking, tobacco, alcohol, milk formula, and the like. So we've always seen business as the enemy. When Legal & General, big financial institution, insurance company, approached me and said, we have 1.3 trillion pounds. I can't get my head around that. I didn't buy peaches because they were £1 a peach. I can't get my head around 1.3 trillion pounds. We have 1.3 trillion pounds under investment, and we want to know what we can do in our day job that improves health and reduces avoidable health inequalities. And we said 3 things. Good employment practices, pay everybody a real living wage, security of employment, training, etc. Government, are you listening? That's what we'd like for the nurses, please. Sorry?
The fee award is on the table, it's not tightly installed.
The second, goods and services. I said before, you know, if you're selling tobacco, there's no way you can be a health promoting company. Your product kills people and you're in the wrong business. And I said to Legal & General, what do you do about it? You don't sell products in that way. They said, yeah, but we're big investors. And you probably know that corporations talk about ESG, environment, social and governance. And Nigel Wilson, the chief executive of Legal & General, said, I want to make it ESHG. Talk about environment, social, health and governance. And we can channel our investments. If we think a company is damaging health, that's not a good investment risk for us. So goods and services. And the third is the wider impact on the community, the environment. In the healthcare system, we talk about anchor institutions having a positive, wider impact. So that's very important in the whole employment area. So I want government to address my 6 recommendations, but I would like them to say equity of health and well-being is our priority. I mean, when New Zealand said our economy is going to be based on well-being, I wrote to colleagues in New Zealand and said, I need to know what you're doing there. So they sent me a statement from the Treasury. It read like it could have been written by Amartya Sen. I mean, it was about people's capabilities and to capacity to lead a life of well-being. And that's what we'd like government to do, to have the health and well-being and equity of health and well-being as the priority. So that's what I'd like government to do.
One of the figures in these reports this week is, if you start at the beginning, infant mortality is 2.5 times higher in the poorer areas than in the richer areas of the country. So when you're looking particularly at the health and well-being of mothers and prospective newborn children, what are the measures that you think should be introduced to deal particularly with that issue?
Well, the infant mortality one is really worrying. Not just is it 2.5 times, but the gap's getting bigger.
Yes.
And the Scottish report, and English figures are similar, but the Scottish report shows that it's actually going up.
Yep.
It's actually going up in the more deprived areas and stop declining in the less deprived areas. So the gap's getting bigger. And if we put it in context, you might say, well, come on. I'm thinking of Benjamin Seaborn Rowntree in York at the beginning of the 20th century, looking at infant mortality. And in the worst off area of York, it was 250 per 1,000 live births. In the best off area, it was 90 per 1,000 live births. And now we're talking about 2 in the best off area and 6 in the worst off, compared with 90 and 250. So you could say, what are you worried about? It's so low that it's not a big deal. Well, in one sense, that's true. And there was massive improvements in the 20th century. But I think it's an indicator. I'm not sure about the canary in the coal mine. I think we now send coal miners down to see if it's safe for canaries. But I think it's an indicator. It ought to be going down, and if it's going up, it means other things are going bad. So in other words, it's not just what can we do about the infant mortality, but what is it telling us about the conditions of life of these mothers, these women who become mothers. And I think the things we've been talking about. If you're living in poverty, why do women smoke in prisons? Is there a woman in Britain who fails to understand that smoking is harmful for her and for offspring? I think it's probably not. I think everybody knows that. That health education's worked. Everybody knows smoking's bad and you shouldn't do it. A do-gooder like me, well, not really like me because that's not my approach, but anyway, a do-gooder comes along and says, you know, you naughty person, you really shouldn't be smoking. Give me a break. I don't know whether I'm going to have a bed tonight. I don't know whether I'm going to be able to feed my existing children. I'm having trouble with my partner and God knows what, and you're telling me, you're wagging your finger about saying, just go away. I've got other problems to deal with. And I'd like women not to smoke in pregnancy. I don't really like it, but I do understand why the knowledge and information is insufficient. If deal with the issue of homelessness, which is not just rough sleeping, it means insecurity about where you are going to sleep. Deal with having to resort to food banks and other banks to get through the day. And you remember the old work that Hilary Graham did when she was talking to women. And these women who were smoking, when she actually talked to them about their day, the only thing they did in the day for them was the cigarette. Everything else was for somebody else. It was for the kids, for the partner, for this, for that, for the other. The one thing they did in the day that was for them was the cigarette. And you want to take that away too? Well, So what I would do is come back to address the social determinants of health and deal with this rising infant mortality as the indicator that it is and what it's telling us about the conditions of people's lives.
Yep, yep. Unbelievably, we've talked for 45 minutes already.
I just got started.
And people are enchanted to hear what you have to say. But before we ask the audience for questions, maybe one question about the global inequalities in health. If you take child cancer, this has always shocked me. The chances, 90% of those children who get cancer in childhood survive in the richest countries, but only 20% survive in the poorest countries. If you take end-of-life care, this has again always shocked me, 50% of the population, the poorest 50%, get only 1% of the pain-killing drugs that should be available. So 99% of all pain-killing drugs like morphine are in the richest half of the world. Now, what can we do? And of course, only 20% have been vaccinated against COVID in the poorest countries. Now, what would you again be your recommendation about how we could begin to solve what is almost an intractable problem about inequalities across the world, where there's no parent I know who wouldn't want every child who had cancer to get proper treatment and wouldn't want anybody who was in pain to get relief if particularly if it's the end of life care.
Well, so my own involvement in global health has not been on universal health coverage. I'm more in favour of universal health coverage. WHO, the World Bank, various global institutions have signed up to it. And ideally what they're looking at is a kind of nice, one of the good things that happened, I guess, when you were Chancellor, was the National Institute for Health Care Excellence, and looking at what's cost effective. And what's cost effective in the UK is going to be different when you look on a global scale. And I think NICE does a terrific job. It's been criticised because people say, no, you've got to spend all the money there is on my cancer. And so it's a really challenging question. It's a really difficult question when you go globally and say, how do we get the most on balance, cost-effective approaches? How much are we going to spend on this child's cancer? It's a really difficult question. It's not a simple answer. But we're so far from universal health coverage. And I don't think it's conceptually or even financially difficult to make progress. During the pandemic, I reviewed Adam Tooze's book for The Lancet about the pandemic. He had this really shocking statistic that WHO, the World Health Organization's budget, is about $2 billion a year, which is less than the budget of a large inner-city hospital in the United States. One hospital in the United States is spending more per year than the global public health agency. So we have got our priorities really skewed. We could treat more kids with cancer globally. We could give more pain-killing drugs if we got our priorities a little more in order. And again, quoting Adam Tooze, the cost of global rollout of the COVID vaccine would be, what, $20 billion? Something like that. Yeah. So, the rich countries of the world in the first year of the pandemic issued new debt of about $10 trillion. $10 trillion. they issued in debt. Half of that was bought up by the central banks, which Gordon will explain to me why that's not just a conjuring trick, that's something that makes sense. But $20 billion for a global rollout of the vaccine is coffee money. It's coffee money. It's nothing. It's nothing. When you're going to bail out the financial system, that actually it wasn't, it was $18 trillion. It was nearly a quarter of global GDP was issued in new debt by the rich countries. Well, go on, give $20 billion to the global vaccine rollout. You could do it. You wouldn't even miss it. So we've got our priorities really, really screwed.
So, my final question, and prepare to ask your questions, and there will be a microphone coming round for your questions, is Marmot City, Marmot Town, Marmot Council. Explain what that would be, because there's one in Wales, Gwent, they're talking about it in Scotland, there's one in England, and they will be happening around the world. Explain what that's going to be, and whether you think Fife should be a Marmot county.
Yes. People say to me often, you've been doing this a long time. Your statistics are really compelling. I spared you my graphs this evening, but I was describing my slides, they're all up here. Your statistics are really compelling. Aren't you frustrated, disappointed, depressed that you don't seem to be getting action? And I said, no, I'm really excited. Why are you excited? Well, look at what's going on. We've been working with cities, regions, districts, etc. There are two reasons for doing that, a negative reason and a positive reason. The negative reason is I'd really like national government in the UK to take the steps that would lead to better health and greater health equity, to reduce child poverty, to spend on my 6 domains of recommendations. But if they're not doing it, which is what my 2020 report documented, then we need to find another way to get action. And my approach, probably why I'm not a politician, my approach is if I push on a door and it doesn't open, I don't bang my head on the door, I look around for a door that might open. So when, after my 2010 report, when Coventry declared itself a Marmot city, I said, hey, this is really interesting. I'd been to Coventry and talked to them, but this is really interesting. What are you doing? So I went to Andy Burnham, the mayor of Greater Manchester. I said, you know, Coventry's a Marmot city, Coventry. But if Manchester did it, that would be really something. And Andy said, okay, we'll do it. Then I went to Liverpool, said, do you know what they're doing in Manchester? So what are they doing? Let's take Greater Manchester. It took the leadership of the mayor, the political, charismatic, set the right messages. It took the involvement of all 10 local authorities that make up Greater Manchester, but particularly the biggest, the City of Manchester, and the chief executive of the City Council was all signed up, Joanne Rooney, all signed up to this. They had a Marmot implementation group that included the City Council, the health and care system, now the ICS, the integrated care system, education, the voluntary and community sector, the police, fire and rescue service, all the key domains. And now with Legal and General, we're trying to get business involved as well, and to develop plans. And in a way, it's a question, almost a research question. If national policy is going in the wrong direction, how much can you do locally? How much can you make a difference? I doubt that anybody who was over the road this evening at Fife College is in any doubt that you can make a difference with local action. That's what we saw. That's what, that enthusiasm in the room. saying we can make a difference with local action. So when we were, well, Coventry did it on their own, as it were. I made several visits to Coventry. But with these other regions, Greater Manchester, Cheshire, Merseyside, Lancashire and Cumbria, Luton is a Marmot town. They're probably wondering what the hell the people of Luton, what does it mean to be a Marmot town? Well, we worked with them. Waltham Forest, Northam Tyne Combined Authority has asked us in. And now, as Gordon said, Gwent has ambition to be the first Marmot region in Wales. So we work with them. We do have our evidence, but it's very important for our evidence to be worked on, interpreted, strained, censored, whatever, in that particular context. So it's their solution, not my solution, their ownership. I went back to Manchester in October, to the city, and they had a big meeting. They produced a report which was their response to my report about making Manchester a fairer city and what they plan to achieve by 2027, the next 5 years. So we came in with our summaries of the evidence and then worked with all the key sectors. And the assumption is we can make a difference, but we need very pragmatic, practical tools. And one crucial element of it is putting in place a monitoring system so we know if things are working. Manchester has 24 Marmot beacon indicators. Cheshire and Merseyside, for whatever reason, had 22. But it's very important, and I talked to the Office for National Statistics last week about what they're developing. That could be, but the problem is what they're developing is only at local authority level, and you need to get finer grained than that, because it's too crude at local authority level. But the same kinds of measures, so you can say what's working. And I was talking to a group called the People's Powerhouse, not quite in opposition to the Northern Powerhouse, but this is the People's Powerhouse. And I said, my secret wish is that we'll get so many cities, regions, districts acting on the social determinants of health to achieve health equity that the national government will have to follow. And the person said, you just said that in a public meeting. That's not a secret wish anymore. That's a very public wish.
As you know, Michael, Fife is a kingdom, so you could have the first Marmot kingdom. And I know the leader of the council and councillors are here, and they can perhaps look at that. They were talking to you this evening. I'm going to pass over to Arabella for the questions.
Has anyone got a question? I think Kirsty McNeil is the first person who asked me a question, so I said I'd go to her first. I can't see Kirsty. Can I anywhere? No? Kirsty? No? Right.
Sorry, do I need the microphone?
No, I'll repeat it.
Well, thanks. Regarding poverty, which I think was the fourth of your priorities, what do you think about a near universal guaranteed income, which may not be as much as a universal basic income, but it might address it for the sector that needs it most? Thanks.
Right, his question was, what does Michael Marmot think of a near universal salary? Guaranteed income. So not necessarily completely universal, but as near as possible to a guaranteed universal income. What does he think of that as a model?
Well, three comments. Firstly, I'm chairing the advisory group for the Welsh Basic Income Pilot. Now, it's not a universal basic income. It's a basic income for young people coming out of care. So it's a very targeted. But still, it's the principle of give people money, make sure they have enough money, and will that improve outcomes for these damaged young people coming out of care? So it's a principle that could then be further rolled out. The second comment is that essentially what the Chancellor did at the beginning of the COVID epidemic with the furlough scheme was really like a basic income. I mean, you know, it was pretty close to doing that. Now, it was 80% of people's salary, and if you were at the poverty line and you were now getting 80%, you're in poverty, so it was hardly sufficient. But, you know, when needs must, and I think we're close to needs must. If people haven't got it, the reason you've got this project is people haven't got enough for the basics. So we're pretty close to saying we need something like that. There is a group linked to the New Economics Foundation that talk about the social guarantee, and they want to link basic income to basic services and say you need both. And I'd been arguing something like that before I'd even heard of the concept of universal basic income. In my book, Status Syndrome, I just pointed out the obvious, that the importance of individual income depends on what the community provides. If you're in the United States and you have to pay for healthcare and for transport, for education and this, and you know, you pay for everything, then individual income is far more important. If you're in a Nordic country, you know, when the trade unions in the Nordic countries, when they argue, it's much more about are you providing a creche or what are you doing, you know, than it is about pay, because the Chancellor takes half of it anyway. So it's much more about conditions than it is about the level of pay. So the importance of individual income depends on how good and available the general services are. I'd like to see transport free at the point of use. You know, like the health service. Education is free at the point of use. That's a basic service. If you had to pay for it, your individual income would have to be much higher. And we have this rather silly system in the UK which is why I said to my lawyer friend, I don't want the healthcare system to look like the education system where rich people opt out. I'd like it to be like Finland, where there's no private education in Finland, and they have the highest PISA scores in Europe. My third comment, and it's not really an answer to your question, but I wanted to get it in, so when that crazy duopoly of Kwasi Kwarteng and Liz Truss were talking about lowering taxes and, you know, setting the wealth producers free, and I thought there's got to be an evidence base on this. And I found a report, of all places, the IMF, the cradle of neoliberalism. And admittedly, the report said this report was done by researchers and does not necessarily reflect the policy of the IMF. But nevertheless, they looked at data from every country for which they could get data and looked at the correlates of economic growth. And what they concluded is making the richest 10% richer does just that, doesn't do anything else. In fact, it has a slightly negative correlation with economic growth. The way to get economic growth is to increase the incomes of the poorest 60%. So it is kind of related to your question. And so I want to say, Andrew Marr asked me the other night, he said, you're a companion of honour now. You're going to be rubbing shoulders with Rishi Sunak and Jeremy. I thought, really? I don't think that goes with the territory. But anyway, he said, what would you tell them? Well, one of the things I tell them is, you're shooting yourself in the foot. If you want to get economic growth, don't make people of low income poorer. How's that going to grow the economy? If they can't afford to feed themselves, they're not going to buy a new refrigerator, let alone new clothes. They're not going to grow the economy. If you want to grow the economy, make sure the bottom 60% have enough money. And that's how you get, and that's what IMF said the data show. So that's kind of an answer to your question.
Right, Peter's going to come round with the mic if you've got a question. Anybody got a question? There's somebody there and somebody there. Peter, why don't you go to that man, because he put his hand up first. And let it not just be men who ask questions, eh, girls?
Thank you. What I was wondering is there a country that is in a sense the gold standard that we can look to as having dealt with the social determinants of ill health and has equity of access to healthcare? Who should we look at and say, if only we could be like them?
Well, firstly, there's no perfect country, but we are doing a report for the Norwegian government. And that's really odd, because Norway looks pretty good. And they commissioned me to do a report on how they could reduce health inequalities. Norway. In fact, if I can detain us for 2 minutes to tell you a story, I was at a WHO meeting, and the Minister of Foreign Affairs of Norway said, I am a health minister. What I do in my day job has impact on health. He said every government minister is a health minister because what we do has impact on health. I thought this was terrific. So I put it on a slide, and every time I gave a talk somewhere in the world, I'd quote the Norwegian Minister of Foreign Affairs. And I got a phone call from an official who I knew in the Ministry of Health in Norway. She said, you know, you've been quoting our foreign minister. He now is our health minister. And he'd like to meet you. So I went to Oslo and I met him and we had a good conversation. And then my colleague said he's going to come back as Prime Minister. You know, he'll be the next leader of the Social Democrats. And they got voted out. And then they came back. You probably know him, Stora.
Yes.
So I wrote to him. Well, in fact, what my colleague said, write an open letter to him and I'll get it published in one of the Norwegian newspapers. So I wrote an open letter, you know, the challenge, because even in Norway, the health inequalities are getting bigger. And the result was they said, we'd like you to do a report for us on what you can do. And we had the mantra, do something, do more, do better. The idea that there's no perfect country. If you're in a country, if you're in Somalia, which is, I did this review for the so-called Eastern Mediterranean region of WHO. Don't ask me about geography, but for some reason Somalia is part of the Eastern Mediterranean, but there you go. If you're in Somalia, and if you could get clean water to people, that's doing something. That'd make a difference. If you're in Jordan, which has got not bad health, it's actually, do more. There are more things you could do. If you're in Qatar or United Arab Emirates, and GDP of $80,000 per person or whatever, do it better. And so Norway's taken that approach of doing it better. And there are a number of countries, if you look at the correlation between GDP and life expectancy, there's a number of countries that are doing better than you would predict from their GDP. And Costa Rica is one, Vietnam is another one. And I think there's a lot we can learn from these individual countries that are doing better than you would predict from their level of national income. And even Norway wants to do it better, and they're doing pretty well.
risk of dropping away from work, in order to make things more equal, surely that has to be a priority.
Well, we did have a pretty good healthcare system in this country. We did. I mean, if you look, I quoted The Economist. I'm not part of their sales force. I said to these two journalists from The Economist who talked to me, I used to think The Economist was an impossibly right-wing newspaper. And now it looks like a model of sweet reason. And I don't know if it's because the Overton windows moved so far to the right that it's just passed The Economist by. He claimed, one of the journalists said, no, it's demographic. They've employed young people like us and we're dragging it in. Anyway, whatever. But when Lansley embarked on his healthcare reform, so-called, and The Economist said at the time, if you're going to do a big reform, three things are rather important. One is that you know what the problem is you're seeking to solve. The second is you're clear on the destination. And the third is you take people with you. And, said The Economist, he failed on all three counts. We had a pretty good healthcare system in 2010. And we've run it down. As I said, I think it was not just callous disregard. I think it was active undermining. So we know how to do a good healthcare system. What I've been pushing is that the healthcare system needs to address the social determinants of health. It actually needs to address the conditions in which people are born, grow, live, work and age. And I said to your colleagues, your report, The Scottish Future, I really liked the healthcare part of it, because if you go around the world, people say, oh, the problem is that poor people don't get access to healthcare. And as I said earlier this evening, in Britain, that's not been the case. We've had universal access. What Gordon's colleagues said, our Scottish Future said, poor people use the healthcare system much more because they've got more illness. So it's not underuse. It was not overuse, but it's probably appropriate use, but they use it much more. Deal with the wider determinants of health, and you might deal with that excess burden of illness that leads poorer people to overuse the healthcare system. So we've been trying to work with integrated care systems and integrated care boards, urging them to take action on the social determinants of health so that we can reduce that burden on the system. So, in other words, two things. Let's properly fund and staff the healthcare system, which includes, obviously, primary care. You remember when, how many health secretaries have we had since the Brexit referendum? 5, 6, if you count.
Since last September.
If you count Steve Barclay as 2, because he's been there twice, I think it's 6. So when one of the health secretaries said, the GPs ought to be seeing more people in person, and then he refused to go to the GP's conference, he didn't want to turn up in person. But so it means paying proper attention to primary care and staffing our healthcare system properly. That's one. But the second is getting the healthcare system to address the social determinants of health. I can't quite hear you.
Can't hear you.
Have you got the mic?
Is it on, Peter? Maybe just...
I work as a data journalist, you know?
Can you put it closer?
Okay, I work as a data journalist for the NHS, so I'm really heartened to hear about you talk about evidence-based decisions, data and statistics. I'm interested in your comments about some success stories you had over the last few years. So I'm particularly interested in your thoughts on things like the vaccination programme for HPV and the benefits it's had on the poorer community, the lower SIMD, the outcomes for women with respect to cervical cancer, so much better for the lower SIMDs, and how those stories can be replicated across the health service.
I mean, let me just say again for the third time this evening, what I focus on is not the NHS. It's very important to all of us, as I said, but that's not what I've been looking at about delivery of services. A lot of people who are looking at it, very important question. My own view, and that's why I liked the first part of our Scottish Future paper, my own view is that we pay attention to the social determinants of health, because that affects the treatment people get as well as their need for treatment. So I'm not the best person to comment on the specifics of particular services. That's not what I do.
The lessons we can learn.
Sorry?
Lessons we can learn
From the use of statistics.
from the use of statistics.
Oh, from the use of statistics. So,
Yeah, the lessons we can learn from the successes we have.
so the data are absolutely vital. I've had to learn some lessons that there are other ways of knowing things, because I came into this saying if we haven't got the numbers, we haven't got anything. And people took me by the hand and said, no, there are other ways of knowing things. There's evidence from people, which is right. But when I was talking in answer to Gordon's question about Marmot cities or towns, I said we need a monitoring system. Everything we do is looking at whether we're making progress. And the reason we know we're in trouble is because of the statistics. And this rant that I referred to in the Lancet about post-truth and science, I said that the data are absolutely crucial. I referred in that essay, I said when I was in Berkeley, I went to a philosophy of science seminar when Paul Feyerabend was writing his book Against Method. And he was a complete absolute relativist, if you can be an absolute relativist. But you know, that the pre-Socratic's approach to science was just as good as Newton. Newton was just as good as Einstein, and you judge it all in its own terms. And I thought it was terrific and dazzling and exciting. And I thought, that doesn't work for me. In medicine, if you go to your doctor and the doctor says, take this treatment, it'll reduce your risk of recurrence of breast cancer, you're entitled to ask, how do you know that? And if he says, I made it up, well, that's not very helpful. And if I say, I think that if we reduce child poverty, that would be good for health and health equity, that's because I've looked at the evidence and I believe it's so. And in fact, forgive me going off in a different direction from your question, but in fact, I then went on to ask the question, what's the worst crime a scientist can commit? Qua-scientist, I mean, he could do other terrible things, but qua-scientist. And the answer is lying. Stealing somebody else's ideas shows real respect. I mean, it's reprehensible, but hey, that's terrific. I wish I'd thought of that. I'll steal that. So that's, I'm not recommending it, but it shows real respect. But lying, the whole enterprise collapses. The whole enterprise collapses. It's the worst sin a scientist can commit. And if you know, think if you said, you said in the paper you wrote 5 years ago the opposite of what you're saying now. And I say, no, I didn't. Now I'm sounding like Donald Trump. It's garbage. I mean, we've got nowhere. We've got no basis of communication, no basis of discussion. Science can't advance. We don't know whether we're doing good or bad. The evidence is crucial, and telling the truth about the evidence is crucial. And that's absolutely vital. And everything I do is based on that. As I said a bit earlier, I had to be led by the hand and taught that there are other ways of knowing things, that the evidence from people is important too. But that's not instead of, that's as a complement to the statistical evidence.
This is the last question, and I'm glad to say it's from a woman. Not that there's anything wrong with men, but we've had 3 men. Here's the second woman. Yes, with the blue scarf. Oh, she knows my name. I don't know.
You know me. Thank you so much. That was fantastic. Can I possibly ask 2 questions? One, the UNDP report this year on unsettled, uncertain times, unsettled lives, picked up that trust has gone. It's anxiety and trust is fractured. And what you're saying is a response to that. And I wonder, could you just say a little more? And the second question, which ties in, is this call for the kingdom, the Marmot Kingdom of 5 here. What are, say, the 3 things that we should be doing tomorrow, next week? Because we can do things. You've given us an incentive to take things forward. Thank you.
Thank you.
So the trust question. One of the things I cited in this Lancet essay was Ipsos Mori has a veracity index. They say, now I'm going to read you a list of different people. I want you to tell me if you trust them to tell the truth. Number 1, nurses, trusted by 93% of the population. Number 1 is, we doctors aren't far behind. We're not as good as the nurses, trusted by 91%. So nurses, doctors, judges, scientists, teachers, trusted by 80+%. I'm glad he's otherwise occupied. No prize for guessing who brings up the rear. Politicians.
I'm a recovering politician.
Politicians trusted by 14%.
That's an improvement.
Counterintuitively, government ministers by 20%. Journalists, 24%. Just below estate agents. So we've got a real problem. And when you listen to, so Gordon says he's a recovering politician, when you listen to what goes on, and I think every time one of them gets up and talks like this rubbish, it must go down from 14%. I mean, they work hard to earn our distrust. To do that badly, you've got to work at it. And it's appalling. It's absolutely appalling. And I said in this essay that it's tempting to think that it's got worse. I began it by saying, last year, sometime between the Brexit referendum and the election of Donald Trump, I went into a London bookshop and asked for a book on bullshit. And the clerk said, we have a lot of those. Directed me to the politician's memoirs. And I said, no, you misunderstand. I wanted the book by Harry Frankfurt, who's a professor of philosophy at Princeton, called On Bullshit. and I talked about what he said before. But I then looked at, George Orwell talked about it in the 1940s. Machiavelli said that princes who are successful thought nothing of misleading the public. So it's probably gone on for a very long time. My own view, for what it's worth, is that it got worse around the time of the Brexit referendum and hasn't recovered. And that there's something terrible happened. Let me just say what's on my mind. The best speech that I heard during the Brexit referendum in favour of remaining was delivered by one Gordon Brown. And it actually it was at the Hay Festival that I heard you make that speech, and both my wife and I were in tears. And we said, here's somebody telling the truth, inspiring us, giving a reasoned argument. I had no reason to doubt a single word of what was said. It inspired trust. Absolutely vital. And I think that's part of what's gone wrong. I mean, quite apart from, we've had, since the Brexit referendum, we're on our 5th Prime Minister, our 6th Chancellor of the Exchequer, our 5th or 6th Secretary of State for Health. I mean, it's chaos. So the trust issue is absolutely vital, and it's gone down the drain. And I'm sure it's important to recovering our country. And I'd like to think that what happens at city, district, regional level, if Fife becomes a Marmot city, part of what they will deliver is you can trust us. We know we live in this place, and we know if you can't trust us, you'll get rid of us, you'll throw us out, because this is where we live and work, you're our neighbours. I'd like to think that that level of trust is greater at the local level, because you're cheek by jowl with your neighbours all the time. So that's absolutely vital. What would we do tomorrow? The reason I say equity of health and well-being at the heart of all policy, because all of these things have to happen. I want child poverty to go down tomorrow. I want us to start working. I want Sure Start Children's Centres to be re-established tomorrow. I'd like to be working on it. When I did my 2010 report, we had figures from the Millennium Cohort study of the social gradient in reading to children. And the more deprived, not surprisingly, the less frequently do people read to their children. And I was presenting this, I think we were in the Northeast, collection of chief executives of local government and healthcare. And one of the chief executives of local government leapt to her feet and said, "We should implement this afternoon. What are we waiting for?" You know, if parents, for whatever reason, can't read to their children, then we can provide good services. That's what the equivalent of Sure Start was doing, was trying to help families do these things. So I would do all these things. I'd start doing them all tomorrow. I'd take the Marmot 6 and I'd work on all of them, starting tomorrow.
Very nearly coming to an end, and I'd like to invite Wilma Brown to the stage, please, to give the vote of thanks.
Michael, thank you very much for all of your talk to us tonight. I think that you've certainly inspired me And with a bit of indulgence, I'd just like to pick up on a couple of points that you made. I've been writing furiously. I must learn to take shorthand at some point. I think in context, some of the things that you've said about health and well-being is something that would resonate with anybody here who is aware of the crisis in the NHS in Scotland and in the rest of the UK at the moment. Oh, and very quickly, we've had 3 health ministers since Brexit. Robinson, so we've had 3 since then. And I think in Scotland we feel very much that we have had many years of austerity and savings put upon people. And the thing that has always given the most is staff. And now we have all of these vacancies. And in context to that, how staff work so hard with the amount of vacancies that we've got. And also because we have so many more presentations at hospital rather than people seeking help and assistance within primary care and not being able to get a GP appointment for various reasons. And I am not blaming GPs at all because they have a very difficult job as well. The stress, the burnout, the increase in sickness absence among staff is phenomenal, absolutely phenomenal, and is only up every year. But more important, I think the damage that we're doing is to the standards of care that we deliver. And Scotland was very proud to pilot and then implement the Scottish Patient Safety Programme, a fantastic programme that made sure that we had every check and balance to ensure the safety of our patients. And that was from having the right staff in the right place at the right time, the right numbers of staff, the levels, the patients that were coming through, all of these things, the waiting list numbers going down, everything. And what we've ended up with now are people who are registrants, our nurses, our doctors, our AHPs, who are very often missed out of all of this, who are very important in our hospitals. The whole team, the physios, the OTs, the dietitians, the nurses, everybody working together to make sure that patients get the right care at the right time, are absolutely being encouraged almost to forget about the standards that they deliver. Standards that are held to through the codes of conduct from the registering bodies, and that is absolutely destroying staff. They go home at the end of the day under a huge pressure of guilt that they have not been able to deliver the care that they want to and the care that they are trained to deliver to patients. And they come back the next day, never been able to unburden that guilt, nowhere to share it. So the health and well-being of our staff, in my view, and maybe people would say, well, you must earn enough money to live on, but in my view is far more important than pay, far more important, because we are losing people. It's morally wrong to treat our staff the way that they're being treated, and that inflicts then onto the care that our patients receive, and that is outrageous. And one of the other things that you raised, which was actually really key, was dignity, and about patients having dignity. And that is what staff want to give to patients every day, at all times. And that's not possible at the moment with the capacity at the level it's at in Scotland and not having enough space, care home. Also dignity for poor patients that find themselves in delay of being discharged. They're medically fit to be going home to either their own home or a homely environment, but they can't be released from hospital because they don't have those spaces. And they're then called bed walkers. And that is just horribly wrong, that we call anybody, any name in a hospital, but that is just horribly wrong, because they do not want to be there. And that's a huge, more points. That's also a huge problem for staff, that they see this happening to patients, because they get to the end of a programme of rehabilitation, mainly people in latter years, get to the end of a programme within hospital of rehabilitation, and that programme closes. And if we don't keep up that care, those people will begin to deteriorate again. And we're putting people through these cycles every day because of what we've got going on. And I think that the care packages within social care, the staffing levels within social care is something that we need to get right. We need to get that right to be able to move people through the system at the rate that their health needs, not at the rate that we need for capacity. We need to be able to do this to keep the dignity for patients and to maintain our staff at the best of health and also being valued at their workplace. And my final point was around, you mentioned the priorities in global health, and I just wanted to give a little example of a project that I'm involved in Malawi. Unison Scotland are building a women and babies clinic in Zomba in Malawi. We've had to pause it during COVID, but we're back up now, the foundations are in, we're just about at window level. And I had a huge argument with the British ambassador in Malawi when we were taken to his opulent home and security everywhere and offered all sorts of food and drink when I'd come from Zomba where people hadn't eaten for days. And he said, oh, you almost patted me on the head and said, there, little girl, you don't know what it's like here. We just can't get antibiotics out to people. And I was silent. I couldn't believe what this arrogant person was saying to me. And once I kind of got my composure back, I said, no, wait a minute. I have been down every dirt road and track around the Zomba area to meet women with their babies and help them to get to hospital, to look at the schools, to do all of these things. And on every corner, down every dirt track, there is a shop that sells Coca-Cola. So if you can get a Coca-Cola van and a Carlsberg lager van down all of those roads, put the antibiotics on them. So the priorities are wrong, and they're not just wrong in these countries, they're wrong in this country as well. I don't want your team. So thank you, Sir Michael. It's been absolutely wonderful. I think you've given everyone in here such inspiration to go out and do these things. And I was desperately waiting for those 3 things that we're to do tomorrow. And I will be feeding this back into the health board at NHS South. So thank you very much, Sir Michael. Thank you, Lord. Thank you so much.
On the 12th of May, is that right? Yeah. And then the rugby person one, and then the one with me.